Hi, I'm Sarah Viall, and I am a nurse practitioner at OHSU, as you heard, and I'm going to be talking about newborn screening follow-up for lysosomal storage disorders in Oregon and how we are still working on building a database for those cases with the help of NBS TRN. I have nothing to disclose. And to do this presentation justice and to talk about the modern project we're working on, I feel like I have to do a little bit of talking about my own background, my own professional background. So bear with me for some anecdotal history sharing. But I actually started my career at Children's National Medical Center in Washington, D.C., where I was for about 8 years. And for those of you not familiar with the area, we were located where the red star on the map is in kind of a very dense geographic area, but very small one. And my primary role there was to do the follow up of abnormal metabolic screens within the program. We were a metabolic program of over 10 geneticists. So it was a big group and one nurse practitioner who was me. And it was a decentralized program, really, because we were covering the circled in red states of Maryland in part, Virginia in part, and Delaware later in time. And then we covered the DC program, but there was no formal follow up program within DC. And so it was decentralized how referrals were getting to us. And then we also were not the only referral sites for these states and one territory. We also would get errant referrals from the neighboring states of Pennsylvania and West Virginia. And when you're covering part of multiple states, screening in different ways with different cutoffs, including different diseases with different mechanisms for follow-up, things can get quite confusing. And it was apparent to us that we would need some way of keeping everything straight. In addition, we had a grant through the state of Maryland. We were a recognized referral center only in Maryland at that time when I started. And as part of the grant, we had some data we needed to share with them. So we started a REDCap database. Actually, it started before my time back in 2011. And it was to track cases so that we could provide Maryland with feedback about what we had actually seen and done for Maryland residents. But it was actually IRB approved as a QI or quality improvement project. And the idea behind that was that we could use it in other programs or for our program largely to improve upon what we were doing and to make sure we were taking care of and never losing track of any babies. And so we did a lot of focusing on tracking days of service and timeliness. And that's sort of because that's what Maryland really cared about in terms of the grant. But it became important to us too over time. And I'll talk a little bit more about that. But it was a database that really captured all of the babies referred to us. So any baby with an abnormal newborn screen would be captured. And that included babies not just who were confirmed to have disease, but also where the babies that were just affected by newborn screening because of an abnormal result. We also really used it to think about babies with undetermined cases or where diagnosis was unclear, because in many cases we were following those children over time, but we didn't necessarily give them a formal diagnosis. And so we would just kind of see how they did over the first couple of months, maybe the first year of their life. And then we really used it for our rarely seen analytes and diseases. It was very nice when a baby came in with a really high C3 and we wanted to think back on, okay, well, what was the last time we saw a propionic acidemia? How high was the C3? What were the other analytes? How does this C3 compare to the false positives we've seen? And to kind of use it like that clinically. And then we would often use data, and the slide here just shows a couple of different examples of data that was pulled from that database to share with the larger group, because we did have a large group of metabolic providers and they did all take call and deal with newborn screening occasionally, but not all the time. And so I thought it was very important for all the providers to see and think about the patterns and the trends we were seeing in newborn screening. And so on the left, we had our clinic referral outcomes. We had 254 babies referred in the year 2019, of which 198 were non-disease, sometimes called false positives, and 51 were true positives. And so we would delve into what the true positives were, but I also cared to review what the non-disease outcomes were. And then on the right is our referrals comparing the year 2018 to the year 2019. We saw a major increase in referrals overall, particularly as you can see from sort of the pie charts from the state of Maryland. And that was, of course, the year that Maryland started screening for LSDs. And so it was important to talk about that as a group and what that meant for bandwidth and what that meant for follow-up of all these babies. And like I said, I really cared about the non-disease, not just the true positives, but all babies touched in a significant way by newborn screening. And these were babies that were referred to us that had to come into Children's National, be seen, have a formal visit, have a blood draw for diagnostic testing, and then await results of that testing. And so to me, that is an extremely important group and one I did not want to ignore just because they didn't subsequently get diagnosed with anything. So we had just about 200 non-disease referrals in the year 2019. As you can see, a large majority of these were from the LSDs. And that was really important for us to talk about as a group, to share that feedback with the state programs, and to think about ways to minimize this, to reduce the burden on the state, on the pediatricians, and on us. And we also had in the history of the program, had a lot of galactosemia false positives. And so to see 8 that year was actually really great progress and a direct result of delving into this data and using the database. And because the LSDs were new and included the second tier DNA testing, which was a brand new concept in our area for newborn screening, we really needed to think through this as a group, to review these cases and to talk about what was best care for these individual babies. So this is just an example of some of the false positives that I presented to our group. We went through and talked about the different variants, the compound hets, the significance of pseudodeficiency, and just kind of reviewed all this information as a group to make sure we were taking care of these kids. And this is just something that would not have been possible without a database to look back on. So I was very attached to that. And in general, I mean, for our clinic and our team, we really cared about the newborn screening results that I just went over. But this was a publication we actually used the database to produce. And when I started at the program, the state of Virginia was not recognizing Children's National as a referral center for their newborn screens. And they had several in-state groups that were taking care of these babies and that were excellent. But of course, Virginia's population is largely located in the northern Virginia region, which is just across a river from DC. And so there was a gap in how these referrals were coming through to us. We were experiencing that gap, and it was something that frustrated us because it felt like we were seeing these babies too late. In particular, there was a homocystinuria case that came in, at over 3 months old, which we were really disturbed by. But it wasn't not until we really went back to the database and examined the dates, from a newborn screen being collected to when we actually heard about it, that we were able to concretely provide this data to the state to say, this is what we're seeing, this is how you're comparing to your neighbors. And I think to their great credit, Virginia was very responsive to that. And Children's National, I should say, is now a formal referral site for the state of Virginia. And I would argue Virginia has some of the best timeliness in the United States. But it was in a large part facilitated by our using the database in this way to present this to them. So I was just really pleasantly attached to what the possibilities of using a database would be. But there were some limitations to that database. Because it was set up to provide information back to the states, it wasn't really tracking clinical outcomes in a significant or approachable way that you could look back on. There were no common data elements, as many people who've worked with the larger databases know. I mean, we kind of just made up the fields ourselves. And then they weren't shared externally. It was just a database for our institution. There was no mechanism to share without doing some significant data analysis ourselves. And by the time I was talking, really by 2020, there was over 1,500 distinct cases in this database. So it was a really huge wealth of information. And we'd had some attempts to work with NBS-TRN and collaborate with the Longitudinal Pediatric Data Resource, or the LPDR, because we, of course, wanted to share this wealth of information with the larger community if we could. But we had some institutional hurdles, both administrative and logistic. Some of the contracting pieces were a little challenging. Um, in large part, the issue of having no common data elements would be that you'd have to change your field names and you would possibly lose the data you'd entered before, those 1,500 cases, without doing a lot of legwork, which just no one was available to do at that time. And everybody, our team at Children's was very attached to this database and was just not prepared to possibly lose that information in some kind of merge. Plus, many people felt, there are other databases that exist for diagnosed cases, and those could be contributed to in a different way. And then I made the decision for personal lifestyle reasons that I was going to move to the Oregon area and take a position in the Metabolic Genetics Department at Oregon Health and Science University, or OHSU, here in Portland. And then that position included some work with the Northwest Newborn Screening Program, which is in Hillsboro, Oregon, not too far away. And this is a picture that I took, I think, like my first week in Oregon. I had never seen Mount Hood, believe it or not. I had never lived in a city where mountains were on the horizon, so I was so eager to snap this photo. And then, of course, I think everybody in Portland could take this photo a million times, but it had meant a lot to me. A little bit about the Northwest Newborn Screening Program, located again with the red star on the map. This was a crazy change for me because I was basically going from the tiniest geographic but most dense population area in the United States almost, to an enormous geographic area that was very sparsely populated. Because the Northwest Newborn Screening Program, while it's located in Oregon, actually covered other states and territories. At the time I started, it was covering 3 states and then 3 territories. And there were differences between these programs. So some states were 1 screen, some were 2. They were screening for different disorders. But they were all covered, the metabolic diseases, I should say, were all covered by OHSU. And it was initially just the 4 physician metabolic consultants at the time. And then it's important to caveat to this move that I made, it all took place in April 2020. So inarguably one of the craziest times in modern history, at least, to make a cross-country move and start at a new organization, particularly a health care organization. And before I even arrived at OHSU or in Oregon, OHSU had declared modified operations, which meant that everything moved to completely virtual. Anything that didn't have to be in person was not. So all meetings, all onboarding, all patient care, in fact, was virtual with some exceptions. But it meant that I was starting a new position in a new organization in a new area without and still subsequently have not met all of my coworkers or team members. And everything infrastructure-wise had to move from paper and collaboration of different colleagues in the office to virtual and shared drives and regular team meetings on Zoom. So it was certainly an interesting time to start and inform some of the subsequent discussion about what we have done and what we've been trying to do. So OHSU and Oregon Newborn Screen, they have a close relationship. As I mentioned, OHSU are the metabolic consultants for the Northwest program. And so we're pretty intimately involved with the program. Oregon is, at the time I started, back in April 2020, was the only state in the program screening for lysosomal storage disorders. And of note, New Mexico did start LSD screening in May of this year, but at the time I started, they had not yet started that. And Oregon actually started back in 2018. They did include 2 of the LSDs from the larger recommended uniform screening panel, or the RUSP. So those are Pompean mucopolysaccharidosis type 1, or NBS 1. But they also included 2 bonus LSDs, or RUSP LSDs, which were Fabry disease and Gaucher disease. And it was a first tier enzyme test followed by a second tier DNA. So, as many people in this group I'm sure are aware, second tier DNA leads to a lot of inconclusive or indirect results that need to be followed up on. Everything is not perfectly clear cut when you have DNA results on board. And the program did have a shared spreadsheet for referrals, and then we had a patient list of known cases, and it was all through shared drive or medical record. And there was also a separate procedure that some of the other staff members were using to track our metabolic traditional biochemical diseases. But only 2 members of the staff actually have access to that. So it was a little difficult for me to sort of wrap my arms around what exactly the referrals had been, what had been the outcomes of those referrals, what variants we had seen, and what sort of what we had done for clinical follow-up of those cases. And I kind of took over LSDs as my own when I started, and so I really started thinking about this very early. How could I develop not necessarily a REDCap database, but some way of thinking about a database that the team could access, particularly in this virtual world. And on top of that, while many people know, I mean, MPS1 screening and Pompe screening are pretty widespread. 27 states are screening for MPS1, 29 states are screening for Pompe, but these are the maps of states screening for Fabry on the left and Gaucher on the right. So only the states in blue, including Oregon, were screening for those disorders, unless you think they're exactly the same. There's a tiny difference, which is the little state of Maryland in blue for Fabry disease, but not yet screening for Gaucher. But basically, there was pretty limited screening experience for these 2 conditions. And so there was a lot of interest in how this was going, what our outcomes had been, what we were seeing, and not just in the newborn screening community, but in the larger metabolic and family group community. So it sounded like the team had actually initial conversations about participating in LPDR. It just hadn't necessarily progressed. And as we were having this conversation, I started talking to one of the genetic counselors who'd been involved in this space. She had been prepping for grand rounds, and she told me she'd run into this issue of attempting to get IRB approval for the presentation, which was a little interesting to me. I had not heard or been familiar with institutions that required IRB approval for a grand rounds internal presentation of de-identified cases, but she told me she actually had attempted to get IRB approval and it wasn't successful because she didn't achieve an approval for exemption of consent. And so I was really curious about this. I had never heard of consent for the presentation of de-identified information. And so I had to dig into this a little bit because she had always worked in Oregon. And that was normal procedure to her, but not necessarily normal procedure to all. So digging into this a little bit, it turns out that Oregon has some of the most uniquely specific genetic privacy laws in the United States, and this goes way back. I mean, these were passed in the early 2000s, I think. So these are not new. But unlike federal law, Oregon actually requires IRB review for even anonymous and de-identified genetic research. So anything that would include genetic information, including newborn screening with second-tier DNA. And of course, research would be anything that is designed to contribute to generalizable knowledge. So that would include a grand rounds presentation. And it explicitly addresses how that consent needs to be achieved. It permits anonymous and coded research using genetic information if the individual consents to genetic research generally, or is notified they would be involved but didn't opt out, essentially. All genetic research has to go to an IRB for explicit prior approval. Unlike the federal approach, which recommends but doesn't require institutions to review potentially exempt research. And when you submit to the IRB, you have to disclose the intended use of genetic information for every proposed project, even anonymous or otherwise exempt research. And there's no exception for federally funded research, and IRB review is still required for secondary research, even though the common rule would not require that. Oregon also imposes obligations on recipients of data sets of genetic information. So that kind of limits even secondary research on these data sets. So this was a surprise to me, and actually to some of the NBS Terrain staff, I think, when we were discussing it, because it is very stringent. And we had to really think about this. I mean, if you want to build a database of newborn screened babies, would you need to obtain consent on every one of them, or would we need to find another way? Because obviously this was a major barrier. But especially remotely, this was a almost insurmountable barrier. We were really struggling to get consent, even for our large pharma funded disease registries, because whereas before people would walk in the office and you could go over this and hand them a piece of paper for their wet signature, we were trying to send these things through the mail and get people to sign them and send them back, and we were just really not having a lot of success. It was a pretty limited response rate. And not only do we want to think about how can we get around this, I mean, we wanted to actually, we didn't want to skirt the rules. We wanted to honor the intent of the law. Obviously, this is something that's been on the books, is important to the state of Oregon, and so we don't want to just kind of get around it. So we talked to NBS Terrain about some options for how we could potentially still participate or include our data in their LPDR database. So we talked about universal subject identifiers rather than patient names or identifiers. We could edit the fields and take out all the PHI. We could limit genetic information. Obviously, the newborn screening information, genetic information, was really paramount importance to include, because that's sort of the point. But maybe we could limit all the other genetic information to keep out diagnostic genetic information, since newborn screening has its own special rules that are slightly different than diagnostic genetic information. So we did submit our IRB with the help of NBS Terrain. We submitted an IRB minimal risk protocol requesting exemption from consent. We specified there would be no PHI shared externally or collected, in fact, and that any research would be strictly anonymized aggregate data. And regarding genetic information, that we would not include any diagnostic DNA results, except for very limited information about whether they were pathogenic or not. But we would include second-tier targeted genetic test results that the newborn screening program had provided us. And that protocol was approved, so there would be no PHI included. We took out, instead of name, we did a subject identifier. Instead of zip code, just how many miles from specialty care, changed all the dates of service to age at date of service. And very limited diagnostic genetic information. So really just the number of variants, the classification of that variant, those variants, and then the number of variants shared with parents. And then, a code is kept at OHSU, but never shared with external providers to keep track of which baby corresponds with which subject identifier. So then we started working on building the database, and just to get to the punchline, we are still working on this. We have made a lot of progress. We're getting very close to finishing, but it's still kind of an ongoing project. The biggest thing was altering all the PHI containing fields to make them still usable. We thought a lot about audience, and that was probably the most important thing. We obviously want to share with LPDR and with our larger community, but we also wanted to be able to provide information to the Northwest Newborn Screening Program, who was desperately seeking information about how this was going, how this process was going. During the course of us building this database, they actually considered proposals to remove Gaucher disease and Fabry disease from their screening panel, and so this information was really important to them. And in terms of outcomes. And then obviously within our institution and department, as I had done historically, to share what the experience of newborn screening had been and the outcomes of our patients, and as well as with the larger metabolic genetics community. Scope, we had to think about at first, and I continue to think about, but really this was built with LSDs in mind. Particularly with that second-tier DNA result. But because I'd had the history of working on a database which collected information about all abnormal screens, And because when you build something this large, you want it to be useful to you even maybe 5 years down the road. We did build it to make it capable of capturing all abnormal screens in case that's a way that we choose to use it. We thought about whether just to do organ babies or to do any baby referred to OHSU, and that was addressed in the IRB proposal. But we did include all babies that would be referred to our care, and how long to follow them. As everyone knows, there's certainly long-term clinical follow-up databases for the LSDs that are ongoing, but those don't always capture these indeterminate or unclear diagnoses where we're not quite sure what to call these diagnoses. And so I wanted to have the capability to follow these people over significant periods of time if we wanted to or if we needed to. And so it was built really to track through childhood even into adulthood, and that includes the clinical outcomes. And it started, we really took all of we begged, borrowed, stealed most of our fields, mostly from the LSD specific projects, some from the more broad long-term clinical follow-up projects, and then we did add, certain questions that I had found helpful from my previous database work. But it started with about 900 fields. Initially, we're using Excel to make edits and collaborate on this with NBS trans staff, but I found that really challenging. I think my brain just doesn't quite work that way. And so we were able to move to kind of PDFs with text edits, and I found that a lot more approachable. Then you can kind of see how everything's laid out. This is just an example of some edits that we were giving on one of the projects pages, and I think it's easier for me to see how it all looks. And like I said, we're still working on it. I think we're very close to going live, to be very honest, but we're still learning. I'm still learning all the time, and have learned some important lessons, which I'll share. Considering audience and use early, but also often, and more importantly, often. I think there were times that I was trying to edit fields and think about how I wanted things to look or what I wanted them to ask. And it was always helpful to ask, or when NBS and stuff would say, okay, well, how are you going to use this field, or how are you going to use this information? How would the state use, this newborn screening program want to use this information? So it's not a one-time thing, at the beginning. You have to really think about it throughout. Embracing brainstorming and just feedback. I've used many of my team members here at OHSU to brainstorm, to think about how these fields were working, how user experience would look, especially because they might be participating and certainly will be participating in this database. And I think it's the kind of project you can't do by yourself. You really need other people to take a look at it and think through it with you. Branching logic as friend and foe. I really love branching logic and wanted to use it all over everywhere, but I think sometimes it gums up the works a little bit more than you need to if you use it too early. So I encourage you to think about it, but to maybe incorporate it later in the building of your database project. And of course, entering real case is really the only way to do this. I mean, if you want to see how the flow and usefulness of the project is going to go, you have to put in cases and actually, do the data entry yourself. And don't rush. We've been working on this, I would say, about a year, and I don't see how it could have happened any faster. It's really a project that takes some patience and thoughtfulness, and I don't think those things can be rushed. So I just want to say thank you to NBS-TRN. We're very much looking forward to the final database. And here's a picture of Mount Hood. I was able to get a little closer in the last year than that picture of it on the horizon, and it's a beautiful place. So I've been very happy to be here. And thank you very much.